اسمحوا لي معلش انا بحب اقف اشوف وجوهكم وانا بقدم السيشن الجديد، ما بحبش اتكلم وانا ظهري ليكم يعني، فاسمحوا لي اقدمه وانا standing in front of you all. Good morning first. We are now to extending our echocardiographic imaging track regarding important cardiac chambers. Now we are shifting to another important chamber, which is the right ventricle, which is unfortunately is most probably missed in our echocardiographic routine study, but by the end of this session, I think we will put into our consideration to focus on the right ventricle in our measurements and interpretation. Now we will start. Dr. Ala موجود? Okay. Now we'll start with Professor Ala Roshdi, Professor of Cardiology at Ain Shams University, who will give the first session about assessment of right ventricular function from A to Z.
Ramon, thank you very much for the introduction, and thank you for allowing me to share in the annual CardioEgypt. My talk today will be about right ventricular function assessment from A to Z. I will try to be concise as much as I can. The right ventricle is actually a forgotten chamber. Routine transthoracic echo in common practice is a left-sided assessment with special emphasis on global and regional function. Even the patient, after ending the exam, is asking about his ejection fraction, so it is a very well-known left-sided examination. And we have to remember that we have 4 cardiac chambers and 4 valves, and the right heart assessment is usually reported in very few words, stating normal right-sided structures. So what does actually normal right-sided structures mean? Do we mean a normal dimension or normal function, normal pressure, normal tricuspid? What actually does a normal right-sided structures mean? The right ventricle is an unusual chamber. It has different portions: an inlet portion, a trabecular portion, and outlet portion. This would lead to some difficulty in estimation of the RV volumes because it is rather crescentic in shape, with separation between the RV inflow and outflow, and we have no uniform geometric assumption as we have in the left ventricular volume assessment. Also, there is some difficulty in delineating the endocardial border owing to the well-developed trabeculations, and difficulty in adequate image acquisition owing to the location just behind the sternum. There is difficulty in standardizing the evaluation method of RV function because there are variations in direction or location of the RV, and it is easily affected by preload, afterload, and even the LV function. There is also complex contraction relaxation mechanisms, and it cannot be entirely imaged in a single view. In addition, the coronary supply of the right ventricle is not that simple. It is almost supplied by the 3 major coronary vessels, unlike not only the right coronary in a number of patients. So how to start with function assessment? We need to know how to size the right ventricle. Normally, the very classic sizing is by eyeballing. Normal RV is approximately 2/3 of the size of the LV or less. RV dilatation appears similar or larger than the LV size, and it shares the apex formation with the left ventricle. Here we can see on the left side a normal apical 4-chamber view where the right ventricle is smaller in size than the left ventricle, while on the other side we have a large dilated right ventricle with an apex forming right ventricle, denoting right ventricular dilatation. In addition to the eyeballing, we have to standardize some measurements to obtain suitable measurements to be able to follow up these patients. We have to measure the diameter above the tricuspid valve annulus. This is an RV D1 in this image. The mid RV cavity and the distance from the tricuspid valve annulus to the RV apex, and these are the normal reference values for these dimensions. This would be rather important for patients in which we have special interest to follow up the right ventricle, as we will see in some patients later in the presentation. And in other patients, we have also to add the right ventricular outflow tract assessment because it is of special importance in certain diseases like patients with tetralogy of Fallot or even post-tetralogy of Fallot repair, where there is a patch angioplasty with dilation of the right ventricular outflow tract, and we need to thoroughly estimate the diameter and the size of the right ventricular outflow tract in patients with severe pulmonary regurgitation and those where RV to pulmonary artery conduit is planned. And these again are the normal values for the right ventricular outflow tract diameter. We have two diameters to be measured here, the anterior diameter in the outflow of the right ventricle and the diameter just below the just preceding the pulmonary annulus, in addition to the main pulmonary artery diameter. And these are all the reference values. Even we have reference values for males and females in all these dimensions. Then we go to the RV function. Why should we measure RV function? RV is not just a conduit of blood flow. It has its unique function. It has a prognostic significance in various clinical settings, and risk stratification or guidance to optimal therapy is also one important issue to assess the right ventricular function. Visual estimation of the right ventricular free wall and tricuspid valve motion is usually done routinely, but we have some more objective measurements like the tricuspid annular plane systolic excursion, the fractional area change, the tie index, and the tissue Doppler systolic signal velocity of the lateral annulus. All these measurements have their own normal values we have to be familiar with, and we have to use whenever indicated. One of the very easy to apply and very important tool is the TAPSE, or the tricuspid annular plane systolic excursion. Its normal value is from 1.7 to 2.6. Values less than 1.7 is considered abnormal, and it is well correlated with right ventricular ejection fraction. It is reproducible and have a strong predictor of prognosis in patients with heart failure. This is how we routinely measure the TAPSE. The right ventricular fractional area change is also one of the simple methods to use by tracking the area in the diastole and systole, as we see here in the image, and applying these measurements to the equation. We come out with a percentage value which can be followed up. Normal systolic function is usually 35% or above. It is simple, using standard apical 4-chamber view, and it is reproducible, but minds the trabeculations while tracing the fractional area, and it has also its prognostic role in patients with heart failure or pulmonary hypertension. The tie index is a little bit complicated because we have, as we mentioned earlier, we do not have the inflow and the outflow in a single view. So we need to assess the tricuspid inflow pulsed Doppler and the right ventricular outflow tract pulsed Doppler, and then apply the equation to obtain the tie index with normal value of 0.28. And we may use the tissue Doppler to make it a little bit easier to obtain the myocardial performance index or the tie index. And also the tissue Doppler has its role in obtaining the S dash wave, where the pulsed Doppler sample volume is placed in either the tricuspid annulus or the basal segment of the right ventricular free wall, and then the S velocity is read as the highest systolic velocity without overgaining the Doppler envelope to obtain this function. Of course, right ventricular function using 3D echo is having its very important prognosis, and many literature correlate these values with the gold standard CMR, but some limitations exist. Some vendors do not still have a dedicated software for the volumes, but this is becoming less and less. And now the recent machines can routinely obtain the right ventricular volumes. It is, of course, simple, reproducible, and of prognostic value. These are the reference values for the right ventricular function using different modalities we just talked about. There are specific diseases in which we are in particular interested in assessing the right ventricular function, and the right heart pathology may be congenital, it may be acquired, it may be myocardial, for example, in cardiomyopathy, especially in patients with arrhythmogenic right ventricular dysplasia. RV infarctions, although not very common, but it has to be assessed. Tricuspid regurg and pulmonary regurg, of course, if they are organic, we have to properly assess the right ventricular function, and we still have a post-ventricular effect on the right ventricle with patients with pressure overload, either due to pulmonary arterial hypertension or in patients with left-sided cardiomyopathy with back pressure to the right side. In arrhythmogenic right ventricular dysplasia is primarily a progressive replacement of the right ventricular myocardium by fatty and fibrous tissue, and patient present with ventricular arrhythmia of left bundle branch block, congestive heart failures, heart murmur, or even sudden cardiac death. There are echocardiographic features including right ventricular focal dilation of the or aneurysm, thinning out, hypokinesia of the right ventricle, excessive trabeculations, and hyperreflectiveness of the moderator band. These are the criteria to diagnose the arrhythmogenic right ventricular dysplasia. In the guidelines for the diagnosis of pulmonary hypertension, the ventricles are specifically measured and having their own area to assess. They state in the guidelines that the right ventricle to the left ventricle basal diameter ratio more than 1 or flattening of the interventricular septum indicates pulmonary hypertension. And this is a patient with severe pulmonary hypertension with the full-blown picture with a markedly dilated right side with impaired function and a compressed left ventricle with D-shaped septum and even pericardial effusion. This is a very not nice picture of a severe patient with pulmonary hypertension. And of course, we see here the right ventricle suffering from this marked increase in the pulmonary pressure and sharing its suffering with the left ventricle as well. This is a patient with Epstein anomaly. In Epstein anomaly, we cannot ignore the assessment of the right side. We have to measure the apical displacement of the tricuspid valve. We have to assess the tricuspid valve. We have to also assess the long axis of the right atrium as well as the long axis of the inlet portion of the right ventricle. And then we have to comment on the trabecular and outlet portion and to assess the pulmonary outflow, because some of these patients have a very small right ventricle and usually have a affected forward flow into the pulmonary artery, resulting in what we can call a functional atresia or functional impairment of the right ventricular outflow tract because of the very rudimentary right ventricle. So we have to perform and report in all patients the RV size, basal dimensions, volumes, if feasible, RV systolic function by at least one method of those we have just mentioned earlier. We have to assess the pulmonary artery pressure, and we have to assess the either tricuspid regurgitation or the pulmonary regurgitation to obtain the pulmonary artery pressure, and this is simply what it means by normal right-sided structures. Thank you.
دكتور علاء، انا كنت بس عايزه اسال حاجتين. انت ذكرت كل الايكو كارديوجرافيك اسسمنتس اللي احنا بنقيس بيها الرايت فنتريكولار فانكشن. هل انت جبت سيره عن السترين رايت فنتريكولار سترين؟
كان في توك على السترين، فعشان كده
عشان
بس
يعني انت ما رضيتش
يعني.
تجيب
لا عشان الانترست اوف تايم يعني.
لان انا يعني لو هقرا المحاضره دي فقط انا طبعا هدور على الحاجه اللي هي
لا هو طبعا السترين
لانه ده الوحيد اللي هو نون لود ديبندنت ونون انجل ديبندنت، لان كل القياسات اللي انت بتقيسها بتيشو دوبلر والفيلوسيتيز والتابسي والحاجات دي كلها
لود
ديبندنت از ويل از انجل ديبندنت.
هو عشان 12 مينتس فهنشفت السترين تو ذا اذر توك.
مستنيين الفولوينج سيشن. الحاجه الثانيه اللي عايزه اقولها، انت اتكلمت عن الاريثموجينيك رايت فنتريكولار ديسبليزيا واديت لنا صوره واضحه جدا الابيكال بورشن بالفيو، الترابيكوليشنز الجامده والامبيرد فانكشن بتاعت الرايت فنتريكل. عايزه بس اقول اضافه بسيطه ان the first part to be impaired in the right side في هذا الديزيز هو الاوتفلو تراكت. early dilatation as well as hypokinesia of the right ventricular outflow tract. يعني ان احنا بنقيس، عايزه اقول احط فوكس على الرايت ventricular outflow tract اللي انت جبتها في تو proximal and distal. قياسهم لو لقيناهم dilated والاكسكيرشن بالام مود كيرسر لما بحط عليهم is reduced than 5 mm, this is an early echocardiographic sign of arrhythmogenic right ventricular dysplasia even before the full manifestation of the 4 chamber study is available. فده تعليقي على النقطتين دول. لو في حد عايز يعلق او يسال. شكرا دكتور علاء. دكتوره ساميه هتقدم.
I have the pleasure to introduce Professor Hassam from UK, the predictive value of RV longitudinal strain in predicting incident AF and ischemic stroke in the general population.
Thank you very much. My name is Hassam Gindi. I'm a cardiology consultant at the Essex Center in North London. My special interest is device implant and echocardiography. So I'm going to talk to you today about prognostic values of right ventricular longitudinal strain pattern and predicting incidental atrial fibrillation and ischemic stroke in the general population. I'm sorry for the very long title, but it was what I will ask you to talk about, so it's not much. So we all know atrial fibrillation is one of the most common types of arrhythmia, and it's visually exhausting, and it could lead to a stroke. And so what we're trying to do is to identify groups with high risk of atrial fibrillation to help to risk stratify these groups and who will benefit from close monitoring and introduction of direct oral anticoagulants. So moving on, this is the left atrial appendage, and when your atrium is not contracting, you make a smoke, and sometimes you make a clot. And yes, I agree, sometimes you're not sure unless you do a 3D. So if you move to 3D, you can find this very nice thrombus like a tongue moving here, waiting to displace itself in the brain and give the poor patient a stroke. So your job in here is to try to find these patients before this thrombus happen, i.e. once they have atrial fibrillation, you go to them and start anticoagulation and hopefully prevent some strokes. Okay, so we all knew a very long time ago, the patient with LV dysfunction, patient with left atrial dilatation and distension index impairment, etc., have a high risk of developing atrial fibrillation. And in my center, we've done loads and loads of publications. I did loads actually on how we can use the left atrial distension index in predicting the outcome after cardioversion, in predicting the occurrence of atrial fibrillation. We actually didn't look much into the right ventricle. And I'm sorry to duplicate a bit from the previous excellent joke, and I will steal some of it, because there was a lot of challenges associated with right ventricular systolic assessment. There is also, what I'm going to touch on also is a strain advantage, and finally, predicting stroke from the RV strain pattern if we can. So moving on, let's look at the challenges with right ventricular echo assessment, which have been excellently presented in previous talk. We know, coming from England, that we look like a right ventricle, like a bagpipe. So bagpipe is the one used by the Royal Scotland Guards to salute the Queen, and it have exactly the same shape. It is like prolonged, have a bit of a dilatation here and there, a close inlet to outlet, very difficult to image. And if you open it up, there is a lot of trabeculation inside the right ventricle. It got a thin wall, the inlet and outlet are quite close, and so it's really, really quite difficult to have a full assessment in it. So what I did, I chose in 3 cases admitted last month to my place, and asked your help to tell me if we got the right ventricular assessment right or wrong. So this is the first one. This is a patient I was called mid of the night by my registrar saying, well, we don't know if the patient is tamponading or not. We know there is effusion. We know if we look at the left ventricle, it's very clearly not working, severely impaired. But the RV, I'm not really sure if it's impaired, not impaired, hypertrophied, tamponading, not tamponading. So I kept asking him other questions like, did you look at the tricuspid inflow? Did you look at the IVC collapse? But above all, did you look at the blood pressure? Did you look at the pulse? So from multiple questions, you understand there's a lot of limitation to making a decision based only on the right ventricle. Like, move on another case. The patient has some mitral problem, and you could look at the LV, it's quite hyperdynamic. It's actually acute rupture of the mitral, that's not the point. The point, you can assess the left ventricle very well here. Anyone is, even if you've done 2 months of residency in cardiology. But RV, well, I can see the apex of the RV, but we can't. Patient has COPD, it's quite difficult imaging. Another very quick example, a patient came with a blackout, came to casualty, echo is normal, and as mentioned in the previous talk, yeah, normal RV size wall thickness. No one looked at it actually, we didn't look twice, and yeah, okay. It's normal. The guy had one blackout. Let's send him home. But before he go, luckily, he had another blackout, and then that was his ECG. He had VT. So we had a look again, and we did an MRI, and we found that he actually had impaired RV systolic function, fatty changes, and appearance in keeping with ARVC. So we looked at the echo again, and we look, let's look at it. Let's make it work again. It's not working automatic. So not very clear in the parasternal view, but if I take you to the apical view, now we can appreciate that the RV, when you measure it here, is not really coming together, it's hardly contracting. So we come with the idea that the RF ventricle is actually impaired, and this patient have RV dysplasia. Right. So there is different modalities, as mentioned before, to assess the RV function. You could look at right ventricular end diastolic and end systolic dimension. You could look at TAPSE. You can look at S velocity, and you could look at IVRT, etc. So when you have multiple parameters, that simply means that you don't have a specific parameters which give you exact answer. So when was the subject of the talk was how to correlate the RV systolic strain to the prediction of atrial fibrillation with multiple modalities. All your sensitivities is gone. You have a very limited prognostic power in a large number of patients when you are counting in loads and loads of numbers. Therefore, we move to the RV longitudinal strain pattern to overcome these limitations because, as mentioned, it's angle independent, load independent, etc. So let's move to the strain. We, again, in my place, we have done loads, and we published actually chapters in books about strain and speckle tracking that in the context of left ventricular function. So we, in simple, I know not all of us have done a strain. In simple terms, the strain is something your eyes can catch because it depends on the longitudinal function. Your eye can catch only the side to side. So if I don't know what's your favorite movie, but if it is the Game of Thrones, you will just see a movie. But if you watch a Charlie Chaplin movie from 1920s, you will see it like pictures after each other quickly because your eye can catch this. So longitudinal strain, you depend on the computer to tell you what your eyes can see, and it's very important. So basically, the idea is very simple. You have a fixed apex, and it measures the elongation and shortening of the wall towards this fixed apex. So you got in the right side, these are color codes, and if you are near the apex, you move very short distance. At the base, you move a longer distance. So you measure point A to point B, how long it will take to move from point A to point B, and depend on the time it will take you, you have a color code, and in the color code, you look on the right-hand side, you have 12 till 0, where 0 is no movement, so 0 gets the orange, i.e. when you are at the apex, you move 0 towards the apex. When you are at the base, you move a lot towards the apex, so you got this move color like this is 12, right? The idea is very simple. It's moving in that longitudinal direction, which your eyes can't get, but the computer can get it for you. Very reliable, does not depend on you, but depend on the computer and AI, right? So, before you apply your strain to the right ventricle, you have to get a conventional RV focused chamber, not a beautiful conventional chamber like this, because that won't give you the strain pattern, but you probably look at that one. You try to avoid going too posterior to see the coronary sinus. You avoid going too anterior to go to the LVOT tract. And when you draw your picture around the strain, or have done some studies, try to avoid being too high, try to avoid losing the apex, try to avoid being too low, try to avoid to be too external, and then this is actually the correct way you draw your strain in the right ventricle. Is it problem-free? Is it a sort kind of a golden solution? Well, it has additional parameters. The RV function is predictive, reproducible. It is load independent, angle independent, highly available, low cost, very important low cost, short scan duration, and you don't really need to train anybody. The computer does it all for you. However, disadvantages are no agreement about normal values. There's two ways of doing RV assessment. I didn't want to do that to prolong the talk, but there is a 3 kind of segment pathway and the 6 segment where you introduce a septum. You need a high tempo resolution. You can do it when you have AF or very unstable cardiac rhythm, and obviously you have to see the endocardial borders properly. So there is a rule in predicting atrial fibrillation with the right ventricular strain? So this is the question. Right. So in that kind of, there's a lot of studies, but I chosen one kind of close in Oxford. We've just been in the process of publication. We're collecting cases for it. About 3,000 patients. You excluded patients who are known to have previous atrial fibrillation, have previous stroke. You adjust for age, sex, weight, etc. And your primary endpoint is either incident of atrial fibrillation, like these patients develop atrial fibrillation, or if they have a stroke. And you look at the composite endpoints. So we follow these patients up to 5 years. So I will just summarize the finding. For every 1%, in red here, reduction in right ventricular strain, you have a 9% increased risk, 9% increased risk of developing atrial fibrillation. As simple as that per year. So every 1% reduction in the RV strain gives you 9% increased risk of developing atrial fibrillation. So what does that mean basically? It depends on your centile. The higher, the lower the strain you have in your right ventricle, the higher the chance you're going to develop atrial fibrillation in the coming years, and the follow-up for 5 years. This is, in summary, therefore, we summarize that as this have shown again and again, the right ventricular imaging remains a big challenge. We know strain and speckle tracking add useful tools of the RV assessment, and in the low-risk general populations, the RV longitudinal strain pattern is another novel prognostic information in long-term risk of assessment atrial fibrillation and ischemic stroke. And it provides an important prognostic information beyond Chad-Vasc score, CHARGE-F score, in finding these individuals, in trying to identify them and write it to the GPs and monitor them very closely. Hopefully you catch them before they go to atrial fibrillation and see them in stroke. So remember, years ago, before direct oral anticoagulant were kind of discovered, many patients, we find the RNF at the time they come to us with a stroke. The idea is to catch them before they go into AF and markedly reduce the stroke. So thank you.
Thank you very much, Professor Hussam. It's elegant talk as usual. I want to ask you, in the stage of reduction of the strain of RV and prediction of AF, is it indication to start anticoagulant?
What's that, sorry, again?
Start anticoagulant when RV strain is reduced?
No, of course not. What it say, very good question, thank you, but it's not. What it is, you identify these groups and then monitor them closely. Either there's a lot of ways you can monitor them long term. Maybe ask the GP to repeat a cardiac memo on them every 6 months. Maybe do ECG on them every couple of months, so that when they are in atrial fibrillation, hopefully when you find they go to atrial fibrillation, you start the anticoagulation.
Thank you. Any question?
The oblique layer of the left ventricle. So sometimes when the right ventricle becomes dilated, so some of the longitudinal fibers and some of the transverse fibers change its direction to be more oblique. So that does affect the value of strain when you measure it in such patients?
I'm sure it does. I'm 100% it does. But what we don't forget, what we are looking here is blank numbers, prediction, probability, assessments, not science. So what it is, yes, it does, and I'm sure it does. But when you look at the way strain function and move, I think the AI adjusts itself. I don't know how to say, but it is like comparing people to each other. So yes, it does in some individuals, does more in more individuals, does less in normal individuals, and then the whole mechanic and mass of the strain were adjusted based on population.
Thank you.
Yep. Yeah. Yep. Yep. Absolutely. Yeah.
الليفت باندل برانش بلوك.
Absolutely.
فاحنا اول نقطه خدناها استفدناها هنا حسينا ان الدكتور حسام بيدينا نقطه او لايت ان احنا بنقيس السترين على الفري رايت فنتريكولار وول علشان تو افويد ان احنا ندخل السيبتم في قياساتنا دي. مش هقول حاجه ثانيه.
معلش بقى هنتكلم عن
شكرا يا دكتور.
العفو. اوكي شكرا ميرسي جدا. سوري يس.
Thanks, Dr. Hussam. I would like to ask why, when studying the right ventricle strain, and we find that the threshold is critical, as we said in the numbers, do we have to correlate it with the left atrial strain when you are speaking about the AF? Or
we don't.
They should go in parallel?
For the sake of the talk, for the sake of the research we have done, you always find that the RV strain is affected the LA strain, and therefore, yes, in part, it goes in parallel in a way, but that wasn't the topic we looked at.
I mean, should we, for example, when we find the left atrial strain affected, it's more appealing to go with the AF risk than the RV strain?
The ideology is LA strain is affected very later on after the RV is affected. So the idea is, because as I said, although I've spoken of LA when we did our work in my place about LA distension index, we did not only look at patient with dilated LA, but Will's distension index and strain was affected. So this is the further step after RV strain is affected. We usually trying to catch early, and we found that the RV strain goes very early before even the LA strain is affected.
And what about the right atrium in this consensus?
Yeah.
Is it
okay? Thank you so much, Professor Hassam. It's my pleasure to introduce the last speaker in this interesting session, Professor Azza Farrag. Professor Azza Farrag. Professor Azza?
Now, Dr. Mohammed Abul Qasim from Ashut, will be on post-CABG RV dysfunction, another enemy behind RV assessment in TAV upcoming issue.
Thank you. Thank you for the attendance, and thank you for the organizing committee for inviting me to present this topic. As we see, the title of my topic is a little bit confusing, but I will try to do my best and to make it more simple. Transcatheter aortic valve implantation, TAV, is an established treatment option for patients with symptomatic severe aortic stenosis at moderate or high risk operative risk. The right ventricular enlargement and RV dysfunction in severe aortic stenosis patients is assigned to the chronicity and severity of pressure overload as a consequence of left-sided valve disease, aortic stenosis, and the pulmonary artery hypertension. TAV can reduce the LV hypertrophy, but the degree of diffuse interstitial myocardial fibrosis is not changed. This results in diastolic dysfunction and high LV end diastolic pressure, causing post-capillary pulmonary hypertension. And the improved stroke volume after TAV increase systemic venous return, which could accelerate the dilatation and failure of the RV when combined with pulmonary hypertension. As we see in the first and second lecture, assessment of the RV function is challenging due to its complex morphology. Assessment of RV function in patients with severe aortic stenosis using TAPSE, fractional area change, and RV tissue Doppler imaging showed a prevalence of RV dysfunction of 29%. RV global longitudinal strain assessed by speckle tracking echo better correlates with cardiac MRI imaging evaluation of the RV function compared to the conventional methods. Recently, more and more studies are paying attention to the prognosis of tricuspid regurg and RV dysfunction on the outcomes after TAVI. This is a systematic review and meta-analysis evaluating the impact of tricuspid regurg and right ventricular dysfunction on outcomes after TAVI. As we see, all-cause mortality outcomes after TAVI was significantly higher in patients with tricuspid regurg, RV dysfunction, and RRV dilatation. So, and the conclusion of this meta-analysis was both baseline moderate or severe tricuspid regurg and RV dysfunction worse the prognosis after TAVI. RV dilatation is additionally related to increased all-cause mortality after TAVI. This is another paper regarding the pre-procedural right ventricular longitudinal strain and post-procedural tricuspid regurg predict mortality in patients undergoing TAVI. This is examples of RV strain analysis by speckle tracking echo. And the conclusion of this paper was the baseline RV free wall longitudinal strain and the post-TAVI tricuspid regurg was significantly associated with all-cause mortality in univariate and multivariate analysis. Now, patients with post-CABG RV dysfunction who have severe aortic stenosis, is TAVI or surgical aortic valve replacement is more favorable? Of course, this is a hard team discussion. But the guidelines for valvular heart disease in 2021 favors TAVI for patients with previous cardiac surgery, particularly intact coronary artery bypass grafts, CABG, because these grafts are at risk of injury during repeated sternotomy. This is the first enemy in patients with severe aortic stenosis if they have CABG. So this favors TAVI. But as we know, decreased RV function after cardiac surgery is a frequently observed phenomenon. The suggested causes are intraoperative ischemia, intraoperative myocardial damage, cardioplegia, and pericardial disruption. So RV dysfunction after cardiac surgery is another enemy if severe aortic stenosis patients were managed by surgical aortic valve replacement. So the conclusion is TAVI may be the favorable option for post-CABG RV dysfunction, in spite of the data saying that RV dysfunction increases mortality after TAVI. There is an upcoming issue. This is a paper was published in European Heart Journal 3 months ago. It was right ventricular dysfunction after coronary artery bypass grafting. This paper said that if we see RV dysfunction in 200 patients, different methods for assessment of RV function after CABG was used. On the left side, the TAPSI was used to assess the RV function 2 years after CABG, and it was significantly lower after 2 years. So this, if RV function assessed by TAVI, so RV dysfunction occurs 2 years after CABG. But on the right side, if the RV function assessed by fractional area change, we see no difference. Maybe an explanation of this finding that RV assessment method after cardiac surgery may be challenging also because of increased sphericity of the RV following opening the pericardium. So, which method is better in RV assessment post-CABG? This is an upcoming issue, and the conclusion of this paper was RV systolic function was preserved more than 2 years after CABG when assessed by RV fractional area change and 3D RV ejection fraction, despite significant reduction in TAPSI. This study supports the measurement of longitudinal systolic parameters likely underestimates RV systolic function after CABG. And my take-home message is management of severe aortic stenosis is in post-CABG patients favors TAVI. RV dysfunction is one of the predictors of poor outcomes in TAVI. TAPSI may be not reliable in post-CABG patients, and post-CABG RV function should be assessed carefully by the RV fractional area change, 3D right ventricular ejection fraction, and RV longitudinal strain by speckle tracking echo. And thank you.
Thank you, Dr. Mohammed. It's elegant too. I want to ask a question. In which stage of RV dysfunction you will decide the time of TAVI? I need numbers regarding TAPSI, regarding strain. In which stage? To avoid
Yes.
RV failure later on.
Yes, in my topic, I said that RV should be, of course, assessed in severe aortic stenosis before TAVI. And the outcomes of, if we have RV dysfunction, the outcomes is better. After we in severe aortic stenosis, we have to choose between TAVI and the surgical aortic valve replacement. But after surgery, in my topic, I said after surgery, maybe RV function may be worse. So, and the outcomes will be worse also.
There is no alarming number. There is no alarming number.
No,
in strain, regarding strain, or regarding the FAC, TAPSI. You don't have alarming number to push the patient for TAVI. You don't have. Cut it off.
Yeah, for me, I don't have.
Thank you.
شكرا يا دكتور محمد. انا بس كنت عايزه اسال او هايلايت حاجه معينه، ان الحالات السيفير ايورتيك ستينوزيس اللي في السبيسيفيك ديزيز which is cardiac amyloidosis. cardiac amyloidosis معروف ان هو infiltrative disease وانه بيعمل ايه في الهارت ماسل. فلما بنعمل ايكو ستادي بنشوف الليفت ventricle hypertrophied even with normal ejection fraction. الناس دولت قبل ما جو اهيد وعندهم severe aortic stenosis, specific aortic stenosis,
Yes.
because of the position of the abnormal amyloid tissue في الwall of the myocardium as well as the valve tissue. لازم من الناس دولت من اللي نحط فيهم من الناس اللي هم بركز عليهم في study of right ventricular function even if it is normal size
Yes.
and contractility by TAPSI, by S- by eyeballing. These category of patients who are having cardiac amyloidosis who are going to be subjected to TAVI, you should measure the right ventricular function by means
MRI.
of strain.
Strain
To
or
measure the strain across the right free wall. لأن الناس دولت بيجي لهم reduction of the right ventricular function even early, very early. وما بتبقاش متلاحظه لا سيمتوماتيكالي ولا بالتكنيك اللي بنستخدمها التراديشنال ولا حتى بالتيشو دوبلر اكسبت فور دي ادفانسد اللي هي السترين باترن. لو انت عاوز تحطها في التيك هوم مسجز ان هذه الكاتيجوري اوف بيشنتس اللي عندهم cardiac amyloidosis we should have a light on the right ventricular function by strain for early detection of this function لانه ممكن يبقى progress after the intervention.
Yes, I agree.
شكرا.
Thank you.
Now, this should be a symposium by Pfizer for challenging topic, which is cardiac amyloidosis. And it's a pleasure to introduce Professor Azza Farag, Professor of Cardiology, Cairo University. And we would like to congratulate Professor Azza because now she is the Vice President of the Egyptian Society of Cardiology. Congratulations. Dr. Azza, she's an expert and has an excellent leadership and contribution to echocardiography, and she is one of the first diploma في الإيكو في القصر العيني. دكتور عزة عملتها، واعتقد دلوقتي يمكن بقى لنا اكتر من سنه ثانيه مش كده؟ ثالثه. فطبعا دكتور عزه بنحييها على المجهود الكبير اللي بتعمله في
شكرا جزيلا دكتور مجدي، يعني نسير على الخطى ويا رب نوصل لنص المشوار. Thank you very much. My talk today is not a theoretical topic. We want to deliver a message. How could you reach the diagnosis of cardiac amyloidosis in a simple way? I'm sure that you cannot be sure with echo, but you can get a great percent of accuracy when you follow up the steps in a patient you suspected to have cardiac amyloidosis. How can you measure it? By echocardiography. How can you suspect it clinically? And when you can refer this patient for further investigation. So my presentation have 3 phases. First, what is the diastology? Next, the patient, how could it be suspected to have left ventricular heart failure with preserved ejection fraction? And from this, what is the etiology of this HFpEF in the side of cardiac amyloidosis? So first of all, we can say that proper myocardial diastolic function is the basis for hemodynamically effective heart. And any abnormality of the mechanisms determining this normal left ventricular diastole will result in the cornerstone, which is the increased ventricular pressure. I talk here about the left ventricular end diastolic pressure. And of course, we have some impairment of normal blood flow from the left atrium in the pulmonary circulation. First of all, we must say that diastolic dysfunction, it should be very clear. Diastolic dysfunction, the filling pressure, and the heart failure with preserved ejection fraction are not the same. Diastology, in fact, is very difficult to be measured by imaging. It is mainly an invasive assessment. So when you evaluate the diastolic function by routine echo, you can assess the mitral E velocity, peak velocity, mitral A peak velocity if your patient is in normal sinus rhythm, the duration of the A velocity or the duration of A wave, the E over A ratio, the E wave deceleration time, the E prime with the tissue velocity of the early tissue velocity, either in the medial side of the mitral annulus or the lateral side of the mitral annulus. You must know that we don't have 2 annuli. It's just 1 annulus, but you have medial side and lateral side. And you can assess the E over the E prime and the pulmonary venous waves, which is the systolic diastolic velocities and the S over D ratio. This is your routine investigation for diastolic function by routine 2-dimensional echo. And here is the famous figure about the abnormalities in the diastolic function. Remember that I am here not talking about HFpEF. I'm talking about just diastology of the left ventricle. You either have normal mitral flow, impaired relaxation, which is reversed E ratio, or pseudo-normalization or restrictive pattern of the mitral flow with its 2 phases, either reversible or irreversible, according to increase in the left ventricular filling pressure. You have sometimes an aid with a Valsalva to delineate whether this is a true pseudo-normal or normal, but the tissue velocity can replace this Valsalva maneuver because sometimes it became difficult when you ask your patient to form a Valsalva, especially if you know that you have a releasing phase and an initial phase. And of course, all these diastolic abnormalities, you have some of them have normal left atrial pressure, which is first phase or grade 1 diastolic dysfunction, but it's still increased when you reach the pseudonormal and the restrictive pattern. What are the parameters that you should, an equation you should measure when you assess the diastolic function in addition to the usual waves I mentioned before? We have parameters related to left ventricular filling, which is the E over A prime. You have parameters related to the myocardial function itself. Remember, it's called tissue velocity, so it is a tissue function, which is the value of the E wave, either E prime, either in the lateral side of the mitral annulus or in the medial side. Parameters related to left ventricular remodeling, which is the left atrial volume index. Remember always that the left atrium is the window of the left ventricle. So when you look to the left ventricle, you must see the left atrium first. Parameters related to hemodynamic effect of pulmonary circulations. The Dr. Amora Abu Saud asking the last speaker about the assessment of right ventricle when you assess for further therapy, especially if you have patients with HFpEF. So we have the tricuspid regurgitation velocity. Do we have some limitation for these parameters or these measurements? Sometimes the E prime velocity, which is the tissue velocity, is affected if your patient has, for example, and these are not rare patients. If you have patients with mitral regurgitation, this will increase the lensing load. Mitral stenosis, especially if you have calcification, mitral annular calcification, of course, impair the E velocity, if you have left bundle branch block or you have a paced patient, the rocking motion of the left ventricle distorts the E prime velocity, and of course, the constrictive pericarditis, you know that you can judge between constrictive pericarditis and restrictive cardiomyopathy by assessing the lateral E velocity. Normally, it is more in the normal population, and it is less or more affected to be reduced in size in constrictive pericarditis in comparison to the medial side of the mitral aneurysm. And of course, the limitation of the tricuspid regurgitation velocity when I rely upon for diagnosis of HFpEF is if you have pulmonary parenchymal disease or pulmonary vascular disease. It means ان انا ما ينفعش يبقى عندي عيان already هو عنده lung parenchymal disease or COPD or interstitial pulmonary fibrosis or pulmonary embolism or عنده already pulmonary hypertension, and I can rely upon this figure to be one of the parameters of HFpEF. So this all about left ventricular diastology. What about finding HFpEF in practice? This is the first step in your journey to reach the diagnosis of cardiac amyloidosis. Remember that cardiac amyloidosis patients are not plenty. It is a rare disease. But we now, with advancement of imaging techniques, especially in the echo, in the CMR, in the radionuclide imaging, we can reach a lot of patients with cardiac amyloidosis that they are simply missed when you do not take it into consideration. So what do we need to watch out for in HFpEF? Remember, first, a very important point. Heart failure with preserved ejection fraction is a heart failure. You must have patients with heart failure, not patients with left ventricular hypertrophy. If you don't have symptoms of heart failure, you do not need to continue the algorithm I will talk about. Heart failure with preserved ejection fraction is a clinical syndrome defined by the presence of heart failure symptoms and signs. If you don't have heart failure symptoms and signs, don't proceed. Increased level of natriuretic peptide, if you have the facility for this natriuretic peptide, either pro-BNP or the frank natriuretic peptide. Preserved left ventricular ejection fraction more than 50%. And remember very clearly that ejection fraction is not the only surrogate for left ventricular systolic function. You have something else which is called strain. Sometimes the left ventricular ejection fraction is more than 50%, but you have impaired in the global longitudinal strain. Specific structural alterations, for example, left ventricular hypertrophy, are not the only sole criteria. And various degrees of diastolic dysfunction I mentioned before. Remember again that diastolic dysfunction is not a HFpEF. Diastolic dysfunction is just a pattern of mitral inflow or tissue velocity. HFpEF actually represents more than 50% of heart failure cases because it is important. And if we have a drug that works in some of these abnormalities that lead to HFpEF, this is a very strong challenge. The most common cause of heart failure in patients aged more than 65 years and expected to be the most prevalent form of heart failure in the next few years. Why? Because the prevalence of HFpEF increased by 1% per year. This means that after 10 years, we have more extra 10% cases of HFpEF. It is more common in older population, in women, patients with a lot of comorbidities like diabetes, hypertension, dyslipidemia, sleep disorders, COPD, and so on, chronic kidney disease, for example. Patients with HFpEF and atrial fibrillation do worse than patients with HFpEF with normal sinus rhythm. عايز اقول لكم حاجه ان دلوقتي الكرايتيريا for diagnosis of HFpEF does not depend upon presence or absence of atrial fibrillation because we do not rely on any single parameter or the atrial activity. Diastolic dysfunction means increased venous pressure. Whatever the mechanism, impaired relaxation, increased diastolic stiffness, loss of restoring forces, which is the suction, this is very important. All these mechanisms lead to increased left ventricular filling pressure. So what about the algorithm that we can rely upon to reach the diagnosis of HFpEF? Actually, we do have two algorithms. One of them I prefer, and the other, because I think it is more systematic, which is related to the Heart Failure Association. But the H2FBF score also can be used clinically. It talks about body weight or body mass index, hypertension, atrial fibrillation, pulmonary hypertension, being elderly, and of course the filling pressure. And you have a score of 9 points. If you reach some of these points, you can have a great accuracy of your patient to have HFpEF. But this is the one which I prefer. This is a very busy slide, so I divided it into different patterns. You have 4 steps to reach your diagnosis of being HFpEF. The step 1 is the initial overview we all met in our clinical practice. First of all, you should take a history about the risk factors and comorbidities of your patient. This increases the chance that your patients have HFpEF. Of course, you must have symptoms and signs of heart failure. If you don't have this, don't proceed. You should rule out other non-cardiac conditions that may mimic HFpEF, like a patient who has a severe chest disease, pulmonary embolism, or whatever. And you should do the standard diagnostic test as you all do in your clinics or on your outpatients. Electrocardiogram, standard echo, again, standard echo, and natriuretic peptide if you have the facility for this, and 6 minutes walk test if you also have the facility for the test. Because in Qasr al-Aini, actually, we have a very long corridor, is about 1 kilometer. From the first end to the last end, in Qasr al-Aini, we have 1 kilometer, so we can very easy to perform 6-minute walk test. So, if you have some of these criteria that's routinely done, you must shift to the other step. The other step is the echocardiographic scoring to prove or to disprove that your patient may have HFpEF. Again, parameters related to left ventricular filling, which is the E over E prime. Here we have the figure of more or equal 15. Sometimes you find in the literature figure 14, it is more than 14, or equal or more than 15. Parameters related to the myocardial function, the tissue velocity itself. You remember the 2 figures, 7 in the medial mitral areas and 10 in the lateral. If you have figures less than these 2 values, you have 1 point. Parameters related to left ventricular remodeling, again, I call you that the left atrium is the window for the left ventricle. So if you have left atrial volume index by whatever technique for assessment, remember this is a volume and not the area. So you can make it by 2-dimensional echo, either by any one of the equations, either the area length method or the left atrial septum method or the prolate ellipsoid. Or if you have the 3-dimensional echo, you are lucky enough and have your software for full optimization of left atrial volume, you can find the golden figure, which is 34 milliliter per square meter surface area. Another assessments figures about the left ventricular mass index more than 150 or 122 male on females, and the relative wall thickness more than 0.42. The last thing is parameters related to the hemodynamic effect on pulmonary circulation, which is the functional domain, tricuspid regurgitation velocity, without adding the right atrial velocity, right atrial pressure. Just right ventricular velocity is more than 2.8, and I'm not talking about pulmonary artery systolic pressure. I'm talking about right ventricular systolic pressure or velocity of more than 2.8. We have some minor, the first parameters I tell you about are the major criteria, and you have some echocardiographic minor criteria about the global longitudinal strain. If it is less than 16%, left atrial reservoir strain, as Dr. Hala Mahfouz said, less than 18. And of course, if you have EE ratio not fulfilling the figure of 15. So if you have from 9 to 14, this is minor criterion. In step 2 also, if you have the facility for biomarker scoring, you have NT-proBNP and terminal. It is more than 220 picogram per milliliter, or just BNP more than 80, and these figures are trebled if you have a patient with atrial fibrillation. This is why the atrial fibrillation make the scenario is more worse. The minor criteria if you do not reach such figures, so it's considered minor. How can I assess step 2? If I have a major criteria, I have 2 points for score. If you have minor criteria, I have 1 point for score. So if you collect at the all 2 major and 1 minor, I mean 5 points or more, you have definite diagnosis of HFpEF. If you do not reach the figure of 5, so you must shift to step 3. If you have just 2 points, uncertain diagnosis of HFpEF. What is the third step? Is a functional testing in case of uncertainty. It's called diastolic stress test. I don't know if any one of you know what about diastolic stress test. It's something completely different than the ruling out myocardial ischemia of systolic stress testing. The aim here is to detect left ventricular diastolic reserve, impairment which leads to increase in left ventricular pressure during exercise. And look to this figure. These are two populations. One is normal and one has HFpEF. The patient, or it is not a patient, it's a normal subject, A, can achieve a large cardiac index with minimal increase in pulmonary capillary wedge pressure. But here, remember that I said that left ventricular heart failure with ejection fraction is a matter of pressure, failing pressure. So patient B can reach a lower cardiac index with a large increase in the pulmonary capillary wedge pressure, which is actually the left ventricular end-diastolic pressure. Here, how to perform the exercise test for diastology or diastolic heart failure, which is the supine bicycle ergometer. It's very better than the treadmill exercise, the normal, and of course, remember that you cannot do it with the butamine, because with the butamine, you cannot guarantee which heart rate you can achieve. You must have a heart rate maximum of 110, 115 to discriminate between waves. What we are evaluating in diastolic stress test, we evaluate again the mitral inflow velocities, the E and A prime, the E and A if your patient is normal sinus rest, or only the E if your patient is atrial fibrillation, the myocardial velocities, and the tricuspid regurgitation velocity. The image acquisition will be done at rest, at end of each stage of physical exercise, and of course, during recovery. If you get your patient, have the figures I told you about before, that you reach the figure 15 for the E and E prime. But can I take? بصي احنا ما عندناش حد بعدينا فانا ممكن تديني 5 minutes بس. If you reach the diagnostic values, I mentioned in step 2 that you have E velocity at the lateral mitral annulus less than 10 and the medial mitral annulus less than 7, or the E over E prime more than 15 or more than 14, and if you have the tricuspid regurgitation velocity more than 2.8, or the left atrial volume index more than 34 milliliter per square meter surface area, you must shift to step 4. What is the step 4? Is knowing what is the etiology of HFpEF. HFpEF is not an idiopathic. You have idiopathic dilated cardiomyopathy, but you do not have idiopathic diastolic dysfunction. You have some degree of diastolic dysfunction for aging, but you don't have HFpEF for aging. You must have a disease to for your HFpEF patient. So if we talk about cardiac amyloidosis, clues for clinical examination that might suggest cardiac amyloidosis in case of heart failure. Heart failure with symptoms of other organ dysfunction, such as abnormalities in the peripheral or autonomic nervous system, kidneys and gastrointestinal tract, autonomic dysfunction. Certain subtypes are more common, especially in aged population more than 65. History of bilateral carpal tunnel syndrome, family history of heart failure, or, which is very important, unresponsiveness to heart failure treatment, especially the ACE inhibitors and the beta blockers. So not all patients with left ventricular hypertrophy, or not all patients with HFpEF, not all patients with diastolic dysfunction means that you must consider it as cardiac amyloidosis surrogates. No, these are not cardiac amyloidosis. You must have a clinical criteria and the high incidence of clinical suspicion, together with the echo parameters I mentioned for suspecting your patient with great accuracy being cardiac amyloidosis. Atrial arrhythmia are very common in patients with ATTR wild type, but are less common in the genetic type. The first manifestation of the disease may be stroke, sometimes atrial fibrillation. Infiltration of the AV node may be responsible for death or complete heart block. Cardiac conduction abnormalities in the form of low flow, low grade aortic stenosis. You may have various degrees of aortic stenosis. most of them may be mild to moderate, but sometimes you have severe aortic stenosis in some patients. So amyloid deposit formed from unstable precursor proteins, which is the amyloid protein, can accumulate extracellularly in the interstitial spaces of the myocardium, disrupting cardiac structural function. ايه هم الكاردياك structure اللي حصل لهم disruption? First of all, you have heart failure with preserved ejection fraction from thickening of the left ventricle. Interatrial septal thickening. This is one of the pathognomonic features for cardiac amyloidosis. Leads to atrial fibrillation in some patients. Thickening of heart valves is to some degree and not a great degree of regurgitation. Precardial involvement may make some degree or mild degree of precardial effusion, and sometimes blockage of intramural vessels can lead to ischemia or something like syndrome X. Discordance between left ventricular wall thickness and the QRS voltage, I mean low QRS voltage. دي كانت الكويز الشهيرة لينا واحنا نواب. العيان اللي عنده left ventricular hypertrophy by echo and low voltage by ECG means. But remember, sometimes mixed edema patients have this. Mixed edema patients will have precardial effusion that cause low voltage ECG and left ventricular hypertrophy. So it is not only the shape. These are surrogates that when you collect all together, you can reach the diagnosis. Of course, if you have left ventricular hypertrophy by the ECG, left bundle branch block, AV block, or conduction delay, or any degree of atrial arrhythmias. Again, to increase the investigational technique, this is characterized symmetrically by increased biventricular wall thickness. So I mean, you have some degree of the LVH. It is not an extreme LVH. It's not like hypertrophic cardiomyopathy, for example. The wall thickening contribute to the ventricular stiffening, in addition to the embedding of the amyloid material deposition into between the myocardial fibrils. Left ventricular diastolic dysfunction with the all degrees I said can be present, especially the restrictive pattern in advanced cases. Global left ventricular systolic function is usually preserved, but this is not the case if we perform the strain rate. Strain ratio may be useful for identifying the differentiating cardiac amyloidosis from other disease states that mimic cardiac amyloidosis like LVH from any whatever reason, hypertension, hypertrophic cardiomyopathy, athlete heart, and so on. Look at this. This is a patient with cardiac amyloidosis. If you can see the biatrial dilatation, the thickening of the interatrial septum, and the thickening of the wall of the right ventricle. It's not only a disease of the left ventricle. But if you look carefully here, the apex of the right ventricle is preserved. This is one of the earlier stages of cardiac amyloidosis. So if we perform the pulse-eye illustration of the strain, you can see here 3 types of patients: cardiac amyloidosis, referred to as A, and hypertrophic cardiomyopathy with B, and aortic stenosis by C. You can see only a single appearance for the cardiac amyloidosis, which is the apical sparing. Apical sparing, if you have normal strain, you have a very dark red. If you have a lower strain, you have faint red, or even you have a very light red color. So in the 4 patients with cardiac amyloidosis, you have apical sparing, the apex having a red color. But if you have a hypertrophic cardiomyopathy, you have heterogeneous appearance, especially at the site of the septum. You find the degree, a significant degree of fibrosis, and this will affect the strain rate. In aortic stenosis, the diffuse fibrosis all over the myocardium will cause this appearance. So here are 2 other patients with cardiac amyloidosis. Look at this. Left ventricular hypertrophy, sparkling appearance of the myocardium, thickening of the interatrial septum, biatrial enlargement, some obliteration of the right ventricular apex, some degree of mitral regurgitation, restrictive pattern by the mitral inflow. Tissue velocity is reduced, especially the E velocity. I'm not talking about A velocity anyway. And of course, if you perform the strain rate, you can get the apical sparing figure. maybe this one is not working. Okay. So if you have a great suspicion of cardiac amyloidosis, you have three main parameters. The patient is proved to have HFpEF, amyloid fibril deposit in the myocardium, resulting in thicker and inelastic ventricles, leading to some degree of significant diastolic dysfunction. The ejection fraction may drop later on in the late stages of the disease, but you can pick it up early by strain. You have some degrees of arrhythmias and conduction disturbances, and some degrees of aortic stenosis. Usually it is mild to moderate and sometimes presented with low flow, low gradient aortic stenosis. What are the red flags for suspected cardiac amyloidosis? You have left ventricular wall thickness more than 12. This in addition to the clinical criteria. What are the clinical criteria? Patients in heart failure. Remember that HFpEF means heart failure with preserved ejection fraction. So your patient must have heart failure if it is old age, more than 65 years, if he has aortic stenosis developed very late. Sometimes if your patient is hypertensive, he got hypotension or became normotensive, some sensory involvement of autonomic dysfunction, carpal tunnel syndrome, proteinuria, ruptured biceps tendon, and of course some degrees of arrhythmia. So the take-home message, HFpEF represents a challenging clinical syndrome despite the fact that considerable progress is being made in its overall framework. The diagnosis of HFpEF relies mainly on increased left ventricular filling pressure, which can be non-invasively determined with a great accuracy by echocardiography. It is pivotal to follow appropriate diagnostic pathway. This is very important. You must follow an appropriate diagnostic pathway. ما تمسكش في حاجة واحدة وتقول تبقى هي دي معناها remember that this is a rare disease. This is not a common disease. Starting clinical suspicion, laboratory, and different imaging modality. Early diagnosis of cardiac amyloidosis is the key for determining prognosis. Now, you pick up your patient early, you have a chance for a long time of survival. A high degree of suspicion based on the clinical history and laboratory investigation can lead to early diagnosis and quicker initiation of therapy. Management of cardiac amyloidosis requires actually a multidisciplinary team approach. It is not only the cardiologist, the radiologist, the hematologist, and all other these specialties is necessary to confirm the diagnosis and initiate treatment. Thank you very much.